Michael Warrell, our medical superintendent, HOD Pediatrics, Dr. Kadir from NHM. So we have already seen most of the details about TAEI. I will not be introducing about TAEI from our Government Vellore Medical College. Our Government Vellore Medical College is recently started, that is just 14 years ago in 2005. And we have 100 medical students, MBBS students, and 35 postgraduate students in medicine, pediatrics, surgery, OG and anesthesiology. And our TAEI center is one among the 80 centers in Tamilnadu. This is a level 2 center. They have classification like level 4, level 3, level 2, level 1. I have already explained to you. And we started functioning from last 6 months, from March. Our patient input in emergency has increased almost by 40% for the last 6 months, and our death rate is decreasing. I have explained to you already. And now I am very pleased to invite our state NHM delegates, Dr. Kadir Warrell, he is project medical officer of the state, and Mrs. Lydia, Mrs. Manikandan. And I request our medical superintendent to have a few welcome.
Thank you, Dr. Srikanth. On behalf of our Government Vellore Medical College, I welcome Dr. David Warrell, Dr. Michael Warrell from United Kingdom, and Dr. Anand Zakaria, his team from Christian Medical College, and NHM coordinators, Dr. Kadir Warrell, Mrs. Lydia, and Mr. Manikandan, and other professors, assistants, students, postgraduates, undergraduates, and the nursing students, and others who have come to the forum. So I think today morning we had a nice session, and with the public. There was a beautiful speeches given by our professors, and very impressive skill by the nursing and technical students. I think it was correctly conveyed to the patients what to do and what not to do when there is a snake bite. I think without much delay, we'll go with the other procedures. Thank you, Dr.
It is our culture in India as well as in Tamilnadu to light up the Kuttu Velakku by the dignitaries. We light up the lamp. We straight away go to the scientific session. We will now start with our national mission team. Can I request our dignitaries from the stage to show the introduction? So as you all know, our TAEI is reared by the National Mission of Tamilnadu. The TAEI program started in 2017 by our previous very dynamic mission director, Dr. Dares Ahmed. Now in his place, another doctor, he is also a medical doctor, Dr. Sinjil Raj IAS is now heading the NHM of Tamil Nadu. I request our Assistant Medical Officer, Project Medical Officer for TAEI for entire state, Dr. Kadirveer. He is a postgraduate in public health, so he will introduce about state level statistics. Thank you.
Thank you, sir. Good morning, everybody. I am Dr. David, Assistant Program Officer at NHM, working for Tamilnadu Accident and Emergency Care Initiative. So, first of all, I want to congratulate the Government Vellore Medical College and the team and Christian Medical College for involving in this activity. And we sincerely thank Dr. David Warrell and his team for coming today. And this is the picture which shows about the TAEI program. When emergency occurs, immediately the call will come to ambulance services, which has designated call center. Designated call center 108. After receiving call from 108, ambulance will reach the site, and during transport, the pre-arrival intimation, which is called PAEI shortly, will be given to hospitals, TAEI center, concerned TAEI centers. So, based on the critical situation, our hospital will be ready. The resuscitation bay, if needed, it will be ready. And we have introduced the concept of code blue. If the code blue alarm is given, the hospital staffs who are all inside the campus will gather at the resuscitation site. After doing resuscitation, we will do initial investigation, necessary investigation with POCT, that is point of care testing within the emergency department, and CT scan, X-ray, advanced investigation we will do according to the need. After doing every process, doing elaborate treatment, we will shift the patient to the ward. We are managing the patient 6 hours in the emergency department. After that, we will shift the patient to the ward and we will take up to the rehabilitation. So initially, during development of the TAEI program, we concentrated only injuries. Around 16,000 deaths occurs due to road traffic accidents, and more than that due to other injuries. So we developed TAEI program based on this data. So we felt that only by involving health department, it is very difficult to decrease the mortality. So we involved multi-department in this process. So we divided into 3, that is pre-hospital, peri-hospital and post-hospital. In pre-hospital, we involved transport department, highways and police department and education department. In peri-hospital, we involved police, health, transport and education. In post, we involved health, police and education for giving better life to the victim. So our goal is, previously we adopted the SDG goal, that is reducing the death by half by 2020. But after knowing the other emergencies importance, we set up our goal that we have to develop comprehensive emergency care in the state. So our goal is moved from reducing the death from by half due to RTA to developing comprehensive emergency setup in the state. So our objective is reducing the morbidity and mortality due to major emergencies. So we adopted the following process. In pre-hospital, we have developed GIS of mapping of the accidents, which were the enormous work done by our 108 team. They analyzed the data which available for past 10 years and they have created a grid. Based on that, we have developed this 80 TAEI centers. So the second is dynamic allocation of ambulances. That is, we will place the ambulance in certain areas where the more number of emergencies taken place. That one important step which reduces the ambulance transit duration from the emergency site to that area. Another thing is 108 app and pilot app. 108 app is one thing is called another Avasaram app, which is user-based app. We can download it from the Android. Even without network, we can operate that app for accessing the 108 help. Pilot app is called something like Ola, Uber, where the pilot is using the app, no? Like that, we are also developed the app. And advanced paramedic care and pre-arrival intimation. That is, already we know very well that during transport itself, the paramedic will say that how the patient is critical, and they will request the hospital to prepare. In hospital, we have developed pre-arrival intimation and trauma reception, resuscitation, and point of care testing. And mainly we have created a linkage between multidisciplinary unit and emergency room. Basically the TAEI program is nurses driven model. Usually we believe that the doctors doing excellent work, but it is true, but on the same hand we don't have adequate manpower in the country like India. So we adopted nurses driven model. This is successful in neonatal intensive care unit and other programs. So in emergency also, we decided that we have to develop nurses driven model, and we implemented the same. So in the TAEI activity, we have developed protocol based treatment, and we have done enormous work for the past 2 years. In rehabilitation, our rehabilitation department, we are coordinating that, and we are utilizing their service. So, as we said, apart from trauma, myocardial infarction and stroke, burns, pediatric emergencies are treated under TAEI program. We have administrative structure at the state level, district level, and the hospital level. This makes our job easy. Previously, we don't have clear-cut structure for implementing the program. Because of that, we had lack of coordination with the team. But now, because of this activity, at the state level, we are developing policy by state steering committee. At the district level, we have district committee to implement the program and monitor and evaluate the program status. In the hospital, we are giving freedom to the hospital team to have purchase consumables and take decisions which are necessary to implement the program at the hospital level. So, which already I have told, this is 108 pilot app, this is 108 user app. This is the map which shows about grid analysis. These are the red dots are showing the number of accidents higher in that area. This map is showing about dynamic allocation of ambulances. So because of our various efforts, the response time is reduced drastically in the urban area and also in rural area. In urban area, which is only 8 minutes, which is not shown in the picture, in rural area it is come around 13 minutes. So we have the specified process flow in our emergency department. When the patient comes from the ambulance, our triage nurse will receive the patient. They will take 2 minutes to triage the patient. Based on their need, they will send the patient to the concerned area. That is in triage, in emergency room we have 3 places, that is red, green, yellow. If the patient does not require any admission, they will be sent out as they will be treated as green patient and they will be sent out. If they require advanced treatment, they will be treated in yellow and red area. So this is the picture which shows what are the new steps we have taken within the emergency department. So we can created awareness about the location of emergency department within the hospital site. Previously, it will take at least 5 to 10 minutes. After reaching the hospital also, they don't know where the emergency department is available. But now we have clearly, even you can see well in the Vellore Medical College also, we have created this environment only. That is from the highways to inside the hospital. Clearly we requested the hospital team to place the signage boards. Because of that efforts, we have reduced the time to reach from the emergency place to hospital. Second, there is pre-arrival intimation. this picture, second picture, shows that this emergency technician is calling from the ambulance to hospital to update the status of the patient who is transporting. This is the picture which shows the Green Brigade, who is the one who is shifting the patient from the ambulance. See, this is the ambulance. The patient is shifted by Green Brigades to casualty, our emergency department. After shifting the patient, our nurses receiving the patient and monitoring the vitals for triaging. This is the another process we adopted, that this public address system within the emergency department to develop patient health personnel relationship, good patient health personnel relationship. This is the one picture which you can see clearly. This is the dots which shows the TAEI centers, 80 TAEI centers in Tamilnadu. So after developing this TAEI program, previously our emergency department don't have much equipments and consumables within the ED. Even those who are house surgeons can realize this fact. That is, previously, even last year government review mission has mentioned that we are doing good work by doing triage and all those activities, but there is absence of basic emergency equipment within the ED. So we addressed those problems and we have supplied all relevant emergency equipment from the lower end to higher end. So another important thing is we are giving various trainings. That is, the comprehensive training is TAEI skill grading, which is 5 days training, and we are giving a short duration training also. That is 3 days training for poison management and 1 day training for pediatric emergencies and other trainings. Because of these efforts, we are able to train our medicos and paramedics in a large number. We have established specialized training centers, regional training centers. These are all the numbers showing how many we have trained. This is our another one innovation, that we have developed a separate application for uploading our trauma data. So this is the data which shows how the mortality reduced in Vellore Medical College. Before introduction of TAEI and after introduction of TAEI. Before introduction of TAEI, the trauma mortality is 8.3 in Rajiv Gandhi, and Vellore is here mortality is 0.55. After introducing TAEI, it is 2.7 in Rajiv Gandhi Medical College, and in Vellore it is 0.34. So we have another various pillars like script and STEMI. Also we have developed various innovations. Due to time constraint, I am ending here and I am handing over mic to Lydia to elaborate about poison management, which we have taken a lot of initiatives.
Thank you very much. We have enormous amount of statistics being collected daily, monthly and yearly for the last 2 years. So Sir is so enthusiastic to present so much here. More than the statistics, our death rate throughout the Tamilnadu in the emergencies is dramatically coming down over the last 1 year because of the timely care in within the golden hours. So, as he said already, it is nurse-centric model. Our Madam Lydia is the consultant, NHM consultant. She is the postgraduate registered nurse. She will now introduce one of the pillars, snake bite. Out of 6 pillars, poison and envenomation is a pillar. So about that, she will give the secret.
A very good afternoon to all of you. We, the TAEI team from the National Health Mission, are really grateful for the invitation given by the Dean, Professor Dr. Selvi, and the TAEI Nodal Officer, Professor Dr. Srikanth, all the TAEI nurses, the TAEI team, and all the faculties in Government Vellore Medical College and Hospital for giving us this opportunity to participate in this grand event. We are also very glad to meet Dr. Warrell and Mr. Dr. Michael Wagon, as they are the pioneers in the snakebite research. We are indeed eager to draw inputs from you, as the government of Tamil Nadu's critical priority today is not only the issues due to the communicable, maternal, newborn, nutritional diseases, but also the growing issues due to road traffic injuries, trauma, burns, poison bites and stings, chest pain, stroke and other emergencies. Moving on to brief more about the approaches of the Government of Tamil Nadu to tackle the issue of snakebite envenoming, we would like to keep our presentation as short as possible so that we can hear more from the chief guests today. Firstly, the state of Tamil Nadu acknowledges the result of the million death study, which states that the yearly deaths due to snakebite is 46,000. This is equal to the maternal deaths in the country. Secondly, the state firmly believes that snakebites are completely preventable and treatable. The premature deaths due to snakebite are purely signs of technology failure and research failure. Second slide. The Government of Tamil Nadu has rolled out the Tamil Nadu Accident and Emergency Care Initiative, which aims to provide assured emergency care services to the public. TAEI has been established in 80 hospitals across the state, where the existing casualty or the zero delay ward has been reorganized uniformly and remodified as per TAEI standards, with the emergency room and hybrid high dependency unit. Of the 6 pillars of TAEI, poisoning, bites and stings management has been considered a striking problem of the rural community, and TAEI acknowledges it in the 6 pillars. So it has brought it under the 6 pillars of TAEI. The poison management under TAEI aims to reduce the deaths due to snake bites and poisoning by 2/3 before the year 2023. Thirdly, TAEI visualizes the cause of death due to snakebite envenoming through the 3 delay model, which includes delay in decision to seeking care, delay in reaching care, delay in receiving adequate health care. Currently, the state runs a very sound pre-hospital care system with 936 ambulances. Like how we see in the slide, there are 76 4-wheel drive ambulances which are unique to the state. We do not have such ambulances in the country. Like 4-wheel drive are very unique to the state. It has specifications developed by experts in the state. So these ambulances help to get the patients from the tribal, really difficult to reach pockets in the state. As on date, there are 76 such ambulances. The state also ensures that all PHCs, all government hospitals and TAEI centers have their own crash carts equipped with anti-snake venom. Fourthly, the state recently realized that the venom supplied from the Irula Snake Catchers and Industrial Cooperative Society, the only primary supplier of venom in the country, is with quality discrepancies and not as per the standards recommended by WHO. The Honorable Legislative Assembly member from the Coimbatore district, Pollachi, raised concern over the loss of lives due to snakebite in the reserve forest area of Coimbatore, despite the tertiary care treatment with proper administration of polyvalent ASV procured from TNMSC. TAEI emphasized on the within species venom variations, between species venom variations and between location venom variations, paving way for establishment of regional serpentarium or captive breeding program across the country to produce truly potent good quality venom, thereby seeking for novelty in research and newer technology for ASV production. Next slide. These are few pictures that we collected for the proposal to write to the government for developing state-of-the-art serpentarium. These are some pictures of the interpretation center. Fifthly, TAEI seeks the need for a platform for bioecological domain activation, as killing snakes is not the solution. Lastly, recognizing the data as a key to implementation, TAEI has designed mechanisms to collect data on snake bites on daily and monthly basis by means of Google Forms. This individual tracking is kind of a snake bite registry where the Google form is developed and the link is circulated across the state to all the government hospitals so that the nurses, the data entry operator, whoever is interested, they feed in the data and we get it in the headquarters. And monthly tracking sheets are given to the Directorate of Medical Education, Directorate of Rural Medical Services and DPH, so that the statistical office there will collect the monthly data and give it to us. With these few baby steps taken, the state is committed to reduce deaths due to snake bites. Thank you.
Thank you, madam. We hope we are interesting Professor Dr. David Warrell in Tamilnadu about the snake bite initiative as part of our TAEI, sir. And now I request our department, postgraduate department of medicine, to have a scientific session, a presentation.
I am from the Department of Medicine. I am going to present the current scenario in the Department of Medicine regarding the snake bite. So we all know that snake bite is an important but neglected public health problem in India. We do perform certain cross-sectional studies of snake bite. We did one study last year, 2018. I am just here to present the crux of what we have done. So we had we are admitting nearly 80 to 100 cases of snake bite every month, and we did a cross-sectional study of 522 cases of snake bite which were admitted in 2018. And the scenario is like this. The median age of a snake bite victim was 40 years, very young. They are all breadwinners for the family, so how you can realize how much it is when that particular victim dies, because he is the sole winner of the income for the particular family. And snake bite incidents were higher in the male than females, that is 56%, and more in the agricultural workers, rural population, that is 92%. And the incidence goes up during the monsoon session, that is between July and October. We see the statistics, the cases were around 78 in the months of April. Now it has risen to 161 last month. And 60% of the bites are occurring in the ankle and foot. That is the preferred, most common site of bite. Because most of the agricultural workers, they do not wear any footwear protection. And unfortunately, the species identification is still a bit low. Species of snake bitten are identified in only 4% of the cases, and the proportion of dry bite and envenomation were between 46 and 54% respectively. So more envenomation than dry bites. And of the envenomation that we have received, 20% of them were hematotoxic, and the rest will be the neurotoxic and other local complications like cellulitis. And the median duration of hospital day in our setup ranges between 4 to 8 days. And the interval between the bite and the ASV administration is within maximum in between 6 to 12 hours, depending upon the time the patient reaches the hospital. And now it has reduced the time frame also. And 60 cases were allergic to ASV and they were managed accordingly. And as far as the mortality is concerned, it was around 2.5% because of our effective management. And this effective management not only in the in-hospital treatment, it depends upon the community. When the patient can reach the hospital earlier, then it will be better, so that the mortality rate can be brought down still further. Thank you for the list.
Professor of Pediatrics, Dr. Department of Pediatrics, about snake bite in pediatric age group.
Welcome to all of you, sir. I am Dr. Sharanya, Senior Resident from the Department of Pediatrics under the able guide of our head, Dr. Tamilnadu, sir. To quote one of sir's lines from a study in 2013, India has had a long and a tumultuous relationship with serpents which are both revered and feared here. I'd like to present the pediatric statistics for the year of, for 1 year, starting from September 2018 to September 2019. Total number of snake bite for the 1 year is total 57, and we had a mortality of 0. Non-venomous bite is 36, and total envenomation is 21, of which local envenomation is 10. Like 12, sir. Purely hematotoxic cases 3, neurotoxic cases was 3, and mixed cases was 5. I'll be presenting one case which had both the features, and we had a tough time dealing with him and came out well. Sunil, a 11-year-old boy from Tiruvallur district, which is roughly 100 kilometers from here, hailing from a lower socio-economic status, had an alleged history of snake bite at midnight 12:30 a.m. This boy lives in a kacha house with 12 members in his family, so he sleeps outside, just close to the fields. He was bitten by a snake which the family members identified as the common grate. He was taken to Sholingar GH and given first aid and then referred to us. Child initially had complaints of vomiting and blurring of vision with minimal pain at the local bite area. On arrival to our hospital, boy was conscious, oriented, afebrile, tachypneic with only respiratory rate was low. Local examination, there is a fang mark seen on the left side. There were actually 2 spots, and typical to this Elapidae virus snake bite, he didn't have any signs of local envenomation. Heart rate was normal, only the respiratory rate was depressed. He had only 14 per minute, BP of 100/40. In view of this reduced respiratory efforts, the child was going in for respiratory paralysis. He was intubated and connected to a mechanical ventilator. Also, the whole blood clotting time was more than 20 minutes at admission, and the NG tube inserted showed altered blood. So he was showing features of, he was immediately started on anti-serum, ASV, 10 vials, and other supportive treatment was started immediately. Child at admission also had ptosis, so he had features of both neurological and hematotoxic features. On second day and third day, we still continued injection ASV of another 20 vials because he had persistent ptosis. And on day 2, his respiration had not improved. Only on day 3, the child started having spontaneous respirations. Though after injection ASV, he developed allergic reactions, however, it was controlled with after steroids and adrenaline. Only on day 2, his whole blood clotting time had returned to 8 minutes. Routine ICU stay where he was properly monitored, and ED care, supportive treatment was given. On day 3, he had spontaneous respiratory efforts, and the doses also improved dramatically. He was planned for weaning, and later in the same day, he was weaned to CPAP ventilation. Day 5, after post-extubation, the child was alert, awake, afebrile. He was responding to oral commands with stable vitals, and all systemic examinations were normal. Day 5, he stepped down to ward, observed for 5 days. There was no residual neurological sequelae, and then he was successfully discharged. This was a video of the boy. Video detail. Thank you, sir.
This boy was seen at the Vellore Hospital, district hospital in Aragon. The boy was actually immediately intubated. He was in arrest, so he was not able to breathe also. His respiration was very poor, and the SPO was very low. Intubated and transferred, almost 100 kilometers away from the hospital. And here only we started the ASV, and we continuously monitored. He was ventilated for 1 day, and that day we were able to wean from the ventilator and improved very well this time. In case which we have all the features of anaphylaxis plus neurotoxic and hematotoxic composition. Thank you.
Thank you, sir. So this is the advantage of the networking of hospitals from level 3, level 3, level 2, level 1. Level 3 hospital, College Hospital, nearly 150 kilometers away from here, Arakonam. So patient is intubated right there in the resuscitation, TAEI resuscitation in Arakonam, then brought to this place, so we save. So for the wonderful function today, our dignitaries, international dignitaries, Mr. Michael Walker and Professor David Warrell with us because of our Christian Medical College Department of Medicine. Now I request Professor Anand Zaharia, HOD of the Department of Medicine, CMC Vellore, and I also request you to introduce the dignitaries for this piece. Thank you.
Introducing us to the idea of TAEI. And I think what is very clear and impressive from this whole thing is how government Vellore Medical College is actually taking a public health approach to reducing mortality not just to the snake bite but all varieties of emergency. So I think from CMC side, I would like to bring greetings from our institution and our director and principal. I would like to compliment the work of the government Vellore Medical College and TAEI. Over the last month or so, we've been having some interactions. We've gained insight into the work that you do and also develop a professional and personal relationship, and thank you for that. So this occasion, my task is to introduce Professor Warrell. I think many of you have seen him already on rounds, and I don't really need to say anything. And what is so clear is his passion for snakebite and for the patients. And that is so clear. He is a professor of medicine from Oxford. He specializes in many areas, including infectious diseases and tropical diseases. So he has done work in many areas. But his foremost work right now is actually on snake and venomation. I would say he's one of the most knowledgeable people about snakebite in the world today. Sits on many committees, including the WHO committees. He's the senior editor of the Oxford Textbook of Medicine. The WHO Southeast Asia guidelines, he has been key to that and the revision more recently. So he's a friend and colleague of CMC, and we are very glad to bring him here and introduce him to all of you.
Well, good afternoon, ladies and gentlemen, and thank you very much to the administration of Government Vellore Medical College for inviting us today. I've been extremely impressed with everything I've seen and heard here so far. First, you had this marvellous public awareness session showing people how to prevent and how to respond to a snake bite. That was admirable, because the key to reducing snakebite deaths is community education. And then I've had a look around your emergency department and some of the wards. I've been most impressed not only by the facilities here, but also by the quality of your doctors, nurses, and the quality of care. So congratulations. So I'm going to speak today about the public health importance of snakebite. And it seems to me from at least two of the preceding talks that you're well aware that this is a public health problem, not only in India, but in the world as a whole. Next, please. So, it's estimated that more than 100,000 people die of snakebite each year worldwide. And the slide is meant to show the distribution of deaths around the globe. So, in Africa, there are more than 20,000 deaths. In the Western Hemisphere, relatively few, only about 4,000 deaths. It's in Asia, your continent, that bears the brunt of snakebite mortality, an estimate of more than 75,000 deaths a year in the whole of Asia. But people are most interested in what's happening in India, because, as you've heard from a previous speaker, India has the worst snakebite problem in the world, and they also have the longest and the most intense experience of managing snakebite of any country in the world. So the question is, how many people die of snakebite in India each year? If you look at one of the famous reviews by Kasturi Ratney, they estimated about 11,000 deaths a year. If you look at the official website of the government of India, you'll see a tiny figure, only about 1,000 to 1,500 deaths a year from snakebite in the whole of India. The problem with both these estimates, they only included deaths in medical facilities. They only included figures from hospital returns. They did not account for what we now know to be a majority of snakebite deaths in the community, people dying at home. So the Registrar General of India's Million Death Study, which you've already heard referred to, attempted to overcome this deficiency in mortality data. First of all, they chose more than 7,000 sites around the whole of India in all the states. And these were randomly chosen. They weren't just selected because snakebite was known to happen there. They were randomly chosen. Each of these sample areas had a population of about 1,000. And the cause of death of everyone who died in those sample sites was assessed using the technique of verbal autopsy. Verbal autopsy depends on questioning the bereaved family members and neighbours about the circumstances of the person's death. You can quickly see that if someone dies of a high fever, it would be impossible to say whether it was malaria or leptospirosis or something else like that. It's not a distinctive pattern. But in the case of snakebite, it's a very dramatic and distinctive story. Someone is bitten by a snake, and usually within a space of a few days, they've died. So the association, the causation is quite clear. And the extra studies that were done around the validity of verbal autopsy for snakebite confirmed that it was a very reliable method of assessing death in this particular case. And the results, so this is independent of hospital reporting, this is a community-based study. And as you've heard already from a previous speaker, who gave an excellent review, madam, congratulations. The estimate for the deaths from snakebite in India in 2005 was 46,000. This suggests one death for every 2 HIV/AIDS deaths each year. I'm grateful for your figure, the same as all maternal deaths. So this gives you an idea how important death from snakebite is in your country. This was more than 20 times the official estimate. So your government has been underestimating the importance of snakebite for many, many years based on incomplete records of deaths. Because this was a countrywide study, it was possible to estimate the numbers of deaths in each state. And this is very valuable because if you're dealing with limited resources, it would enable the government to deploy limited resources to the most needy states. And you can see here that some of the states had 9,000 deaths a year, others had relatively smaller numbers. In the last few weeks, I and the other authors of this survey, the Million Death Study, have been updating our figures. And this is not yet published. I'm giving you a sneak preview. We've now got evidence that between the year 2000 and 2017, more than 1 million people died of snakebite in your country. It's a truly colossal figure. There have been only 2 other well-designed national surveys of the sort that you've achieved in India through your Director General. One in Bangladesh suggested 6,000 deaths a year, and in Sri Lanka, a much smaller country, getting on for 500 deaths a year. So these are people who die of snakebite. You might think, lucky to be a survivor. But what happens to the survivors of snakebite? These are some of the lifelong consequences of snakebite in survivors. And here are examples from some of the countries where I've worked. On the left, Brazil, in the top middle, Nigeria, Thailand, and on the far right, Ecuador. These are patients who've survived a snakebite. They have their lives, but they're left with permanent physical disability. In the case of the man on your right, he's lost his leg, amputated after snakebite necrosis and the two boys on your left lost an arm and a leg as a result of snake bite. And here are some other examples from Nigeria, bites by a single species, the puff adder. Mercifully, you don't have puff adders in India. And the man on the left, after a 45-year follow-up with his bite, I treated him for snake bite in the 1970s, and he absconded from hospital, unfortunately, and developed a compartment syndrome, an anterior tibial compartment syndrome, lost the function of his right leg, and his life was transformed from being a productive, contributing farmer to being a beggar, dependent on his family's charity for the rest of his life. The man in the middle has lost part of a limb, and the lady on the left, on your right, is permanently deformed as a result of a puff adder bite. And then there's the phenomenon of malignant transformations. You probably know, on the site of chronic ulcers or chronic inflammation, such as osteomyelitis, you can get malignant, you can get cancer formation. So here are two examples of cancer developing in the site of chronic ulcers following snake bite. But in a way, this is the most unexpected of all these types of morbidity of survivors of snake bite, psychological morbidity. And this has only been revealed quite recently by a study carried out in Sri Lanka, showing that patients who were followed up to 2 years after a snake bite, judged by various scores, a depression score, a post-traumatic stress disorder score, and a disability and effect on employment, these patients had suffered as a result of snake bite. So the burden of psychiatric morbidity after snake bite is enormous. So don't forget, snake bite is a frightening, a horrific experience, and it can leave a permanent mark, a scar, on the psyche of the survivor. As you heard already mentioned, one way of assessing the morbidity from snake bite is the DALI, the Disability Adjusted Life Year. If that's an unfamiliar term to some of you, you should look it up, because it's increasingly used by health economists, by health ministers, by politicians to justify their expenditure on different diseases. This is the amount of morbidity that is created by the disease. And you see, first of all, before I explain what a DALI is, compared to some of the other so-called neglected tropical diseases, like schistosomiasis or lymphatic filariasis or rabies, snakebite results in far more DALIs, disability adjusted life years. So this is what they are. The DALI is the sum of years of life lost and the years lost due to disability. Well, the years of life lost is quite easy to understand. It's the difference between the age of death and the average life expectancy in that particular community. The disability adjusted, the years lost to disability involves a slightly more complicated calculation, including a weighting of the degree of disability. But the sum of these two gives you a quantitative measure of the morbidity resulting from a disease. In the case of snakebite, a very large number of DALIs, or disability adjusted life years, result. So let's look at the epidemiology of snakebite. What activities produce a high risk of snakebite? Here are some examples. It's particularly agricultural workers, so people who work with rubber, coffee, tea plantations. We saw a groundnut farmer this morning bitten by a snake on his hand. Paddy farming, and people are herdsmen. Children are particularly vulnerable. I'll come back to that in a moment. And indigenous hunter-gatherers. Also pilgrims. Bottom left, you see people in Kerala in the Sabarimala. I probably pronounced it wrongly, but it's, you go before dark, before dawn in the morning, you walk barefooted to a site of Hindu pilgrimage. Of course, that's a high risk of snake bite, and it is a high risk activity. You see some agricultural workers there, and bottom right are some people in Africa, some hunters from the Hadza tribe, who run a great risk of snake bite. And here are some examples of different agricultural occupations. Rice farmers top left in Myanmar, farmers in Africa, tea pickers in Sri Lanka, and rubber tappers. The rubber tappers go into the rubber plantations early in the morning before it's light, and they're usually barefooted, and they tread on snakes that are in the rubber plantation. And it's interesting that in Malaysia, where I've seen a lot of patients bitten in rubber plantations, the ethnicity of the victims are Tamil. They're Tamil people who've moved from, probably moved by the British from India to Malaysia many a century or more ago. Now children, I'm glad that paediatrics is so well represented, and we've seen a very interesting patient with in the intensive care unit having had a snake bite this morning. We know from the million death studies that the highest age group risk for snake bite in India is the 5 to 14-year-old. So that's your age group. And 3% of all deaths in India in that age group are caused by snake bite. And it's no surprise to us why children are so vulnerable. I took this picture in Nepal, in the TAEI region of Nepal. See, they've all taken their shoes off, they're having a marvellous time, they're running around in the undergrowth. Children are inquisitive, they're undisciplined, they're enjoying themselves, so they're very vulnerable to snake bite. We've also heard this morning that the highest incidence in the season is during the monsoon. And this is very clearly shown in the million death study. The solid line there are the deaths per month. The dashed line is the rainfall. So there's a very high peak during the rainy season. So again, if you're going to concentrate your preventive strategies and you want to do it most efficiently, you must take into account the fact that that's when most of the bites are going to occur. So how are we going to reduce the number of deaths from snake bite in India and in the world? It's not just an Indian problem. I'm emphasizing that by showing you pictures from other countries. And we can all learn from one another. Different countries can learn from other countries. This is a particularly exciting scene. The project I was involved in Myanmar, in Burma, where we asked community leaders to develop plans for how they might reduce the risk of snake bite in their particular village or town. And we found this was the most productive way to do it, is not to impose ideas from the outside, but to ask the village leaders to come up with their own suggestions, which we then reviewed. And you can see, I think, the enthusiasm here. That's a teacher and an NGO worker and someone working on the TB program. They're all very activated, and it's highly likely that they will implement whatever ideas are selected. And we've seen this in action this morning. I was delighted by the scene this morning under the awning out in front of your hospital. Exactly what's happening here. People are being addressed by an enthusiast. We had a marvellous senior nurse this morning. We had senior doctors addressing people and giving them basic education about prevention. And as you heard, do it right, the right things to do after being bitten. Here are two scenes, one from Maharashtra, from Naryangaon, my friend Dr David Warrell. He and his wife run an admirable hospital in Tamilnadu, which has a 0 snakebite mortality. Just like your department, sir, in the last year in paediatrics. 0 mortality, that's what we're aiming at. And below, my colleague in Bangladesh, Professor Mahmoud Faiz, addressing some fishermen in Chittagong, on the coast of Bangladesh and Cox's Bazar. So what are the messages that we should give? Identify the most dangerous snake habitats, the times of year, the times of day and night. We've already heard about the danger at night of crate bites, people sleeping on the ground, and it's often preferred, the ground feels cooler. If you live in a very hot rural area of India, you may choose to sleep on the ground because it feels cooler, even though there's an increased risk of particularly crate bites. But what we need to promote is safer walking and safer working, because snake bite is an occupational disease, as you've seen already, and safer sleeping. And there are very good data from Nepal that if you can't sleep off the ground, if you haven't got a camp bed, the best thing to do, if you have to sleep on the ground, is to tuck in your mosquito net under the bed mat. Tuck it in thoroughly, and then you will be very well protected from night prowling crates. So protect the lower legs and feet with boots, and here is making this message that if you have to sleep on the ground, make sure that the mosquito net is well tucked in. And it's very good to illustrate these public health messages, as you've done here admirably, I've seen this morning, by employing a local cartoonist, someone who has the gift of producing amusing cartoons to illustrate, to emphasize these very important public health messages. So you see there an example of a recent program in Myanmar. We got a famous Burmese cartoonist to draw these pictures, which people find attractive to look at. This is another thing which I know is a factor here. One of your doctors was telling me that people coming from the hilly areas, particularly across into Andhra Pradesh, often seek traditional treatment first. They not only waste time in getting to hospital, but they also put themselves at risk, because many of the popular methods like tight bands, tight tourniquets, are actually dangerous. So in Bangladesh, we've seen a patient bitten by a non-venomous snake. They brought the non-venomous snake with them, who died as a complication of gangrene, secondary to tourniquets. So these traditional methods, I should say, are not only useless, they're not only time-wasting, they can also be dangerous. So they should be discouraged. But we have to discourage them in a tactful way, because very often the traditional doctors are respected people. So, for example, in Thailand, a lot of the traditional treatment is carried out by Buddhist monks. And Buddhist monks are highly revered in the community. So you mustn't just be rude and reject these methods, you must tactfully explain and educate and get these traditional healers on your side. So top right, in Latin America, these are shamans. Bottom right, an Ayurvedic practitioner in Sri Lanka. And bottom left, Morgan Ban in Thailand, a local doctor, very conscientious, but unfortunately wrong-minded in their management and preventing modern medicine, which you have achieved so successfully in India, preventing the application of modern medical techniques. What about first aid? There are lots of misconceptions about first aid. I remember I was taught as a Boy Scout in about many years ago when I was a boy in England, that a snake bite should be treated by a razor cut and introducing a crystal potassium permanganate. That's terrible, terrible advice. So many of us will have been given wrong ideas in our upbringing, and we have to reject these, be much more critical. This is a very good example of excellent first aid. I'm sorry not all of you can see it. A friend of mine was bitten by a very seriously venomous snake in a remote area of Papua New Guinea. That's close to Australia. And he was miles from any hospital. Fortunately, he found some local people who not only constructed a special carrier for him, a stretcher, but they also volunteered to carry him in relays the long distance. It took him 12 hours to reach the nearest hospital, and he was already developing early signs of paralysis. So this is excellent first aid. And these are some of the principles of good first aid. First of all, reassure the victim who will be terrified, immobilize the whole body, not only the bitten limb. Now we saw in the acted dramatic sequence this morning, they were immobilizing the bitten limb with that splint. That was excellent, except the splints were much too short. To splint effectively, you've got to use long splints. But immobilize the whole body as well, remove tight bracelets from the bitten limb, and the recommended first aid method now is not crepe bandaging, but the application of a pressure pad over the bite site. I'll show you that in a minute. Transport the victim passively. It's very bad to run or walk if you've been bitten on your leg, because the muscles pump the venom out of the site of the bite through the veins and lymphatics and prevent early death on the road. And what you were saying about ambulance services, improved ambulances, motorcycle and vehicle ambulances, with trained staff who can put the patient in the recovery position and guard their airway and even give them early assisted ventilation so they don't die on the way to hospital. Because one of the findings of what is going to be published soon, the revised version of the Million Death Study, will show you how many patients in India die in the ambulance on the way to medical care because they go into respiratory arrest or they aspirate vomit. These things that could be simply prevented by better training for paramedics and ambulance staff. So you're absolutely on the right lines here in what you're attempting to do. These are some of the first aid methods which are very popular, which are not only useless, they're also dangerous. So we see suction, which was very popular in the United States, that can increase the local necrosis. Multiple razor cuts, the sort of thing I was taught to do when I was a Boy Scout. If the patient has incoagulable blood, if they have a coagulopathy, they could bleed to death from these razor cuts. You see the devastating effect of tourniquets. The patient arrives in hospital with a gangrenous hand or a gangrenous limb, and the popular snake stone. You make a cut over the wound, you apply the snake stone, useless, and the patient may bleed to death from the incision. So these are the methods these are the traditional first aid methods that we must politely but firmly discourage. This is the recommended first aid method now by the World Health Organization. This is to apply a pad of any sort of material. It could be clothing, it could be bandages, it could be a bit of rubber car tire. You need to localize pressure over the wound, so you apply it directly over the fan marks. And this is tightly applied, and the idea is that you compress the veins and lymphatics, draining the area where the venom has been deposited, and slow down the systemic spread of venom. This is to delay the onset of life-threatening envenoming, such as respiratory paralysis or shock. So this is the method that's now recommended. I was glad to hear you're using motorbikes. I was asking especially about that because in Nepal they have an enormous problem with snake bite. There are very few roads in the TAEI area. So if you rely on a conventional ambulance, a vehicle, it's no good. They now have this marvelous scheme of recruiting village-based volunteer motorcyclists. So if a patient is bitten by a snake, the volunteer village-based cyclist will carry them to the nearest Red Cross clinic where they can be resuscitated. And this is a real case. This is not a dramatic reconstruction. This is a genuine case. This little boy has been bitten by a cobra. He's showing the early signs of paralysis. His father is sitting on the pillion seat to prop him up. It's quite a good position, actually, to transport a patient with early respiratory paralysis. And he's being driven along a cycle track where there's no road to reach hospital. And introduction of this method reduced case fatality from 10.5 to 0.5%. It was really effective. And that's the team at the nearest Red Cross clinic that received these patients. And that's my colleague and long-term friend, Professor Sanjeev Kumar Sharma. He's one of your collaborators in the paper you wrote recently in the British Medical Journal. He's a really excellent innovator based in Dhaka, the old Gurkha Army Hospital in the TAEI region of Nepal. So now we go on quickly to medical treatment, and I'm only going to give you the principles. I think you need to admit any patient who complains of snakebite for a minimum of 24 hours, and I know how crowded your hospital is. The trouble is that symptoms and signs of envenoming may develop late after the bite. We've seen patients who develop crate bite paralysis 12 hours or even later after the bite. So it's unwise to send patients out before, I say 24 hours as a sort of compromise. I know that may create practical difficulties in very crowded hospitals. At the moment we have nothing better than the 20-minute whole blood clotting test. And I'd like to re-emphasize, this is not a clotting time, it's a clotting test. It's an all or nothing test, the result of which is judged after 20 minutes of leaving the sample undisturbed. And I've been in the hospital this morning, I've seen two very controversial results of the 20-minute whole blood clotting test. So I accept that it's not a perfect test. It's very important to have a clean, dry, proper glass tube. Plastic's no good. Glass that's been washed with detergent or soap is no good. You've got to have the right sort of glass that will stimulate blood clotting in your sample. And I'm hoping that we can introduce a more reliable glass tube for use. So this is not a perfect test, but most places in the world that have snakebite problems do not have the privilege, the luxury of a coagulation laboratory. They can't check with an INR or a prothrombin time, or an activated partial thromboplastin time, or a fibrinogen concentration. They have to rely on a simple bedside test. So until we can develop a better point of care method of measuring coagulopathy, detecting hemotoxic snakebite, we have to just use the 20-minute whole blood clotting test, but do it as carefully and as critically as possible. And finally, the most important question is, does the patient require antivenom? Because antivenom is the only specific antidote we have for treating envenoming. So what is antivenom? I'm sure most of you know, but for some of you who are mystified by what is this marvellous ampoule, this is quickly what happens. First of all, you have to find your snakes, and these Aruna tribesmen, you've heard them mentioned already, from the area of Mamalapura on the coast of Tamilnadu. They're expert at catching snakes. So I went out with them on one occasion. They quickly caught, what is this? Saw-scale viper. And so we can milk the saw-scale viper and get some venom. And we then need a volunteer. We need a friendly horse or a sheep, or it could be a camel. And we immunize it with increasing doses of venom of the medically important snakes of the area. And as you know, in India, that's identified as the big 4 snakes, which you saw on the posters this morning in the public education program. And then finally the antivenom is administered. It has to be given intravenously because it's most effective by that route, but unfortunately that's also the most dangerous route for producing early reactions, particularly anaphylactic reactions. So this is a dangerous drug. It has to be given cautiously, ideally by a medically trained person like a doctor or a nurse or a health assistant, and there must be adrenaline, epinephrine readily available in case there is an early anaphylactic reaction. So, one important thing about antivenom is it's not weight related. The same dose for children as adults, based on the idea that the same dose of venom is injected by the snake, irrespective of the size of the victim. And another thing, I was very pleased to hear this morning in our brief ward round that this hospital is using adrenaline prophylaxis, a small dose of subcutaneous adrenaline. The adult dose is 0.25 milligrams of 0.1%. The pediatric dose would be less, given subcutaneously just before you start giving antivenom. This prophylaxis has been proved by a very good study in Sri Lanka to reduce the frequency and the severity of reactions. And I was delighted to see the 2 patients I saw this morning, 3 patients, they'd all been given adrenaline prophylaxis. Well done. There's a problem with specificity that antivenoms will only neutralize the venoms of the snakes that have been used in the preparation. And again, it was mentioned briefly this morning, there are some venomous snakes in India that are not covered by your polyvalent. Green pit vipers, bamboo vipers, hump-nosed pit vipers in the Western Ghats area on the west coast of India. So, and other species of cobra. There are several species of cobra in India, not just one, not just the famous spectacled cobra. There are 7 different species of crate, not just the common crate, Bungarus ceruleus. And so the big 4 antivenom, which has served so well for over 100 years in India, may have to be redesigned to take account of some of these other species. So the polyvalent antivenom covers the major species, and this is another problem that's become quite obvious in the last few years, that the venom of a single species, like the very famous Russell's viper or cobra, varies throughout its geographical variation. The result is that the antivenom produced using venom from, say, Mamallapuram by the Garuda may be very effective in Tamilnadu because that's where the snakes come from. But if you just go across west to Kerala, to Calicut, you will find the physicians there are very dissatisfied with the effectiveness of the Indian polyvalent antivenom. So again, in the future we've got to take into account this phenomenon of geographical variation. So the indications for antivenom, I think you're familiar with this: shock, spontaneous systemic bleeding from the gums or from the gut, incoagulable blood detected by the 20-minute whole blood clotting test, or from a prolonged prothrombin time. Neurotoxicity, we saw a beautiful example in the pediatric ITU this morning of neurotoxicity caused by Russell's viper, not by cobra or crate. Bilateral ptosis, external ophthalmoplegia, paralysis, the patient couldn't open their mouth or protrude their tongue. And black urine, which could either be from myoglobin, breakdown of skeletal muscle, or hemoglobin from hemolysis. And finally, local envenoming. If there's rapidly progressive local swelling, you may have to consider giving antivenom for that. I said that antivenom was a dangerous drug, And the greatest danger is early anaphylaxis. And this is not allergy, it's not IgE-mediated hypersensitivity, it's direct activation of the complement system by giving this large amount of foreign protein intravenously, which is what we do when we give antivenom. And you know the features of anaphylaxis, they're just the same whether the patient is having a hypersensitivity reaction to nuts or a sting by an insect, just the same features, clinical features. And the treatment is always prophylactic adrenaline before antivenom. If the patient develops a reaction, you give them an intramuscular therapeutic dose of 0.1% adrenaline, which for adults you probably start with 0.5 or 1 milligram of intramuscular adrenaline to treat an anaphylactic reaction. Ancillary treatment may be needed for circulatory collapse, for respiratory paralysis, and on the right, an excellent unit. We're going to be visiting Angamali near Kochi on Tuesday this week, where they have a hemodialysis unit. So you may need to treat patients, particularly bitten by Russell's vipers, to tide them over an episode of acute kidney injury. And this is another very interesting pharmacological intervention. We know that patients bitten by cobras in the early stages of paralysis, the paralysis may be reversed using neostigmine, an anticholinesterase. And you of course have to couple the neostigmine with atropine to block the unwanted muscarinic effects of the acetylcholine, which has a prolonged half-life. Care of the bitten limb. You may need antibiotics if there's an infection. Our surgical colleagues are very important for removing, for debriding dead tissue. And one of the most dangerous and unwarranted surgical interventions is fasciotomy. There used to be a lot of fasciotomies carried out in snakebite countries, including India. But now surgeons are much more critical before they do this. And finally, most important, rehabilitation. This is often neglected with a patient who survives a snakebite may be left with a limb that is dysfunctional. So you have to do your best to restore function through rehabilitation. And at discharge from hospital, we saw this again today on your wards. Patients aren't just sent home, they're given advice about reducing the risk of snake bites in future. They're given a leaflet, one of those excellent leaflets, which they can share with their families and their neighbours. So this is promoting the whole idea of prevention. In India, just a final, I'm nearly finished by the way. In India you have a tremendous array of venomous snakes, lots of different species, very confusing, very perplexing. The ones across the top are the big four, and the distribution of the big four is very wide. You see, this shows the distribution maps for these big four species. And most of them are distributed throughout almost the whole of your country, except the high altitude areas in the far north or the northeast. So this is why, one of the reasons why these species were identified. And these are some of the other species of snakes that occur in different parts of India that are medically important, just to show their geographical distributions. Again, you're very fortunate in Tamilnadu, except perhaps in the westernmost part of the country towards Andhra Pradesh, there may be a problem with green pit vipers. So what are my conclusions? First of all, as you've heard already, and I'm very glad you now recognise that India has an enormous problem with snakebite mortality. And I've updated you. Unfortunately, the number of snakebite deaths in India has continued to rise. 46,000 in 2005. I can't tell you the current figure because the data are not yet published, but I can assure you it's higher. It's a higher figure. And I mentioned that horrific statistic. More than 1 million Indians have died from snake bite between 2000 and 2017. So you as a nation are faced with an enormous problem of snake bite mortality. We also have the additional problem of morbidity. And there may have to be a review of the design of Indian antivirals. And my main conclusion, which I think this audience has already accepted before I started to speak, is that snakebite remains a neglected public health problem in India and globally. And yet, from my brief experience of your hospital and medical college this morning, it's clear to me that you as an institution, you as a hospital, are addressing this public health problem in a very positive, very constructive way. So again, I'd like to thank you for your attention this morning, and very good luck with your efforts to reduce the burden of snakebite mortality and morbidity. Congratulations and good luck for the future.
We are very grateful to Professor Dr. David Warrell. Now I request our postgraduates faculties to interact with Emeritus Professor from Oxford.
Wonderful talk. We are all fortunate to listen to a talk today. And I have one doubt regarding this compartment syndrome. Is there any way to measure the pressure in the limb? And is it useful? Because our surgical colleagues, many times they say, patient is not in compartment syndrome. They look for distal pulses and the sinuses and other things, and then finally they say it's not in compartment syndrome. But we feel that the child is progressing from the distal part to proximal part. Is there any way to assess that one, sir?
Yes, well, thank you. That's a very important question. Traditionally, compartments, you all know what a compartment syndrome is. It's when the contents of a tight fascial compartment, and it's very often the anterior tibial compartment in the case of snake bites following a bite on the foot. It's when the contents of a tight fascial compartment swell as a result of trauma, or in the case of snake bite, as a result of snake venom. So there's an increase in intracompartmental pressure. And when that rises above the fusion pressure, of course, that compartment will become ischemic. And traditionally, compartment syndrome has been diagnosed on the basis of a group of clinical signs. This is what surgeons are trained to do, particularly accident surgeons and orthopedic surgeons. And these signs include a tensely swollen, cold, cyanosed, pulseless, tender limb that is painful on passive movement. These are the classical signs of compartment syndrome. Unfortunately, you can get a snake bite that produces all those signs, even though the pressure inside the compartment is absolutely normal. So the classical signs, the clinical signs of compartment syndrome are unreliable in the case of snake bite. And used to mentioned loss of peripheral pulses, that is not a reliable sign of compartment syndrome. Tenderness on pressure, tense pain, severe pain, pain on passive movement, all these signs can occur without any raised intracompartmental pressure. Your specific question is, how can we measure intracompartmental pressure? There's now excellent equipment for introducing a needle and the sterile precautions directly into the compartment, linked to a transducer, which will measure the pressure. And this is used in some hospitals. For example, in Little Flower Hospital in Angamali in Kerala, in northern Kerala, this is routinely used for tensely swollen snake-bitten limbs. occasions we've seen a limb that really looked like a compartment syndrome and the pressure was low. Now, one other point, it's not sufficient just to measure the pressure once. You need to measure it ideally over a period of an hour or two, because sometimes the pressure will rise, or sometimes an initially high pressure will fall. The only other ways that have been used to confirm compartment syndrome are less direct. For example, CT scan or MRI scan of the compartment, or sometimes you can do a test using a mannitol infusion, and that may reduce the pressure. But it's clear from publications all over the world that compartment syndrome has been overdiagnosed. You were suggesting it was underdiagnosed, but in most parts of the world, compartment syndrome is overdiagnosed. Unnecessary fasciotomy is carried out by very enthusiastic surgeons, and the consequences can be disastrous. If you do a fasciotomy in a patient who has incoagulable blood, who has low platelets, who has no clotting factors, he will have uncontrolled, incontinent bleeding. I remember arriving in a hospital in southern Thailand where we were due to do a snakebite study, and they said, oh, we've got a very serious case, quickly come to the ward. This man had had 2 fasciotomies in his leg, the anterior tibial compartment, and I think the soleus compartment. He required 20 litres of blood, and the blood bank was running out of blood because they'd done the fasciotomies before restoring blood coagulability with antibiotic treatment. So as I say, it can be disastrous. So I hope that's helpful. It's certainly a concern that we miss a compartment syndrome, but in the case of snakebite, I think it's far more likely that we will diagnose it when it doesn't actually exist. And the sort of the situation we described with spreading swelling and extreme tenderness of the limb, absent pulses, that is not indicative of compartment syndrome. Sorry to be long-winded about that, but this is a very important subject. Sorry, you as a surgeon, have I offended you, sir? In my opinion.
Thank you, sir. We are very grateful to the dignitaries and CMC team here. I wish our medical superintendent hospital to present a shawl and sample garland to our dignitary, Sir Dr. David Warrell. Now I request Dr. from NHM to present the shawl and garland. Our Dr. Michael Wong from UP. Thank you, sir. Now I request Professor Raja to present the shawl to Professor Anand Zaharia, the Department of Medicine, CMC. Request Madam Lydia from NHM, Madam from CDSA, Mrs. Banza Supras to receive the shawl from. Thank you, sir. So at the end of the function, we thank all the departments, HODs, the faculties, the postgraduates, nursing students, medical students, and our TAEI team, the nursing superintendent, staff nurses and audiovisual team. The full entire government Vellore Medical College is invigorated with TAEI as well as from the our dignitaries, international dignitaries, Dr. David Warrell sir. Now we are concluding the session. Thank you very much. And national anthem.